Good afternoon. For those who don't know me, I'm Professor Shane Darke, and welcome to the first for the year of our NDARC webinars, broadcast as always live from the palatial ballrooms of Mars. But we've got a wonderful program for you this year, addressing important clinical and public aspects of the drug and alcohol field, which I'm sure all of you will find things of great interest. Now, firstly, while we are widely dispersed, we acknowledge traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. Look, our first speaker of the year this week is Dr. Alice Havard. Alice has got a long pedigree in our field. I had the great pleasure of first working with Alice in the early 2000s here at NDARC on the Australian Treatment Outcomes Study. She subsequently completed a PhD here, then moved to work at Western Sydney Uni and returned to UNSW for the Centre for Big Data Research in Health. She's currently a Senior Research Fellow jointly working at NDARC and Big Data, and she's an expert on large-scale epidemiological data and their health implications. Now, today, Alice is speaking on an incredibly important topic, use, safety and effectiveness of quit smoking medicines during pregnancy, because substance use in pregnancy is a crucial clinical issue. Alice will focus on prescription smoking cessation pharmacotherapies and present data on the number of Australian women using them during pregnancy and looking at the risk of adverse birth outcomes. Now, I'm also very delighted that from the clinical perspective, we were joined in question time by Associate Professor Julia Lappin, who, in addition to being a world-class researcher, is practicing clinician. Julia is the Clinical Director of the Tertiary Referral Service for Psychosis in New South Wales Health. And of course, severe mental illness is strongly associated with high rates of tobacco use. So she's well placed to give us a clinical perspective. Now, look, you may log questions onto the Q&A Zoom function, not the chat function, please. Please put it on the Q&A. I'll at the end relay them to the speaker. We may not be able to ask all of them, but I'll certainly will do our best. So I'm really looking forward to this presentation. So now, Alice, it's over to you.
Thank you, Shane, for the warm welcome, and thanks to everyone in the audience for joining. It's a real pleasure to be sharing with you today the results of 3 studies that we've completed on the use, safety and effectiveness of quit smoking medicines during pregnancy. And I conducted this research in collaboration with colleagues at the Centre for Big Data Research in Health. So let me start by painting a picture of why it's important to study the effects of smoking cessation pharmacotherapies among pregnant women. First of all, smoking during pregnancy is extremely harmful to both the mother and the baby. It's one of the main causes of adverse birth outcomes. So it increases the risk of pregnancy complications, such as placental abruption and placenta previa. It increases the risk of neonatal harms like growth restriction, premature birth, stillbirth, and congenital anomalies. And the harms also extend into childhood, with smoking during pregnancy associated with an increased risk of sudden unexplained infant death and adverse neurodevelopmental effects in children, like an increased risk of ADHD. Now, the prevalence of smoking in pregnancy, thankfully, is declining, but still around 1 in 10 pregnant women in Australia smoke. Unfortunately, the risk of adverse outcomes can be reduced if women manage to quit, especially if it's achieved during the first 20 weeks of gestation. But for many women, this is really hard to achieve. There's support available with psychosocial interventions like counselling, feedback and peer support recommended as first-line options for women smoking during pregnancy. And these are effective for some women, but there is a need to explore alternative or complementary therapies, because under current practice, less than a quarter of women who are smoking early in pregnancy manage to succeed with quitting by late pregnancy. So this is where smoking cessation pharmacotherapies or quit smoking medicines come in. They are one of the most effective smoking cessation strategies available in the general population. But this evidence of effectiveness in the general population doesn't necessarily generalize to pregnant women, because medicines have altered pharmacokinetics and pharmacodynamics among pregnant women. But it does suggest that it's at least worth investigating whether these therapies might be a good option for women wanting to quit smoking during pregnancy. So there are 3 pharmaceutical products registered for use as smoking cessation aids in Australia and in most other developed countries. These include bupropion, which is sold under the brand name Zyban in Australia. There's varenicline, which goes by the brand name Chantix, and nicotine replacement therapy, which is sold under various brands. All 3 of them are subsidised through the Pharmaceutical Benefits Scheme when a prescription is obtained. Bupropion's been subsidised by the Australian government since 2001 and varenicline since 2008. And there have been various forms of nicotine replacement therapy, or NRT, available over the counter since 1997. But in 2008, the patch formulation was what became available at a subsidised price for Aboriginal patients. And this subsidy was extended to the general population, or all patients, in 2011. And then in 2019, NRT gums and lozenges were added to the PBS schedule. But the current study goes up until the end of 2012, and so it doesn't include this more recent development. So when considering whether these medicines might be suitable for women smoking during pregnancy, we need to think about both their effectiveness and their safety during pregnancy. And prior evidence on both of these things was pretty limited. For bupropion, there'd only been small studies that didn't return any conclusive findings. And the other limitation of those studies was that they weren't able to distinguish between bupropion used for smoking cessation and bupropion used as an antidepressant. So that's noting that bupropion is registered as an antidepressant in some countries. But fortunately, we can avoid that problem with observational studies in Australia, because in Australia, the smoking cessation is the only registered indication for bupropion use. For varenicline, for a long time, the only evidence on its safety during pregnancy came from small, uncontrolled studies. But in 2019, there was an observational study based on data from Denmark and Sweden published. And this study found that the risk of adverse birth outcomes was no higher among women using varenicline compared to women who smoked during pregnancy and didn't use varenicline. But unfortunately, many of the estimates from this study were quite imprecise because of the small sample size. So it's not strong enough evidence to conclude that, or to rule out that varenicline is potentially harmful when used during pregnancy. And then prior to the study that I'll present today, there'd been no research on the effectiveness of varenicline when used during pregnancy. For NRT, there'd been much more investigation, but it still hasn't resulted in any definitive evidence. The latest Cochrane review on the topic concluded that there's insufficient evidence to determine whether NRT use during pregnancy increases the risk of adverse birth outcomes. And it also concluded that while there's some evidence that NRT can increase quitting in pregnancy, the evidence is of low certainty. And then observational studies on NRT have returned inconsistent findings. So really, there's still a lack of clear evidence around the safety and effectiveness of these products during pregnancy. And because of that, the clinical guidelines in Australia advise that bupropion and varenicline not be used by pregnant women. Most clinical guidelines state that NRT can be used during pregnancy if the expected benefits outweigh the risk of harm, and if prior attempts without pharmacotherapy have not been successful. But although the evidence around the effectiveness and safety of NRT during pregnancy is still unclear, the general support for NRT use during pregnancy is based on the assumption that it's probably no more harmful than continued smoking during pregnancy. So with that background in mind, we set out to measure 3 things in relation to these medicines. Our first aim relates to their use during pregnancy. Specifically, we sought to determine how many women in Australia are using bupropion, varenicline, and prescription NRT patches during pregnancy. Our second aim was to examine the safety of these medicines when used during pregnancy. So we wanted to determine whether any of these pharmacotherapies increase or decrease the risk of adverse birth outcomes compared to women who smoke in pregnancy but don't receive a pharmacotherapy. And then the final aim was to compare the effectiveness of these products. So that is whether the likelihood of quitting during pregnancy differed according to the type of pharmacotherapy used. So we addressed these aims using linked routinely collected data. We had a cohort of, or we obtained data for all pregnancies resulting in birth in New South Wales and Western Australia in the 10 years between 2003 and 2012. Records of these pregnancies were obtained from the perinatal data collections in each state, where the perinatal data contained detailed information about the pregnancy, including whether women smoke in the first or second half. Also details about the delivery and then the health of the baby. And this information is recorded at the time of birth by the midwife or attending physician. We had these perinatal records linked to records from our National Pharmaceutical Dispensing Database, the Pharmaceutical Benefit Scheme data. This database includes a record for every medicine dispensed that the Australian government paid a subsidy for. And so it includes all records of dispensings of varenicline, bupropion, and prescription NRT. And then records of hospital admissions, emergency department presentations, and deaths for both the mums and the children were linked. And we also obtained records of congenital anomalies for the babies born in New South Wales. So I'll talk you through now how we use the data to address our first aim, which was to determine how many women are using these quit smoking medicines in pregnancy. The pharmaceutical benefits or the pharmaceutical dispensing data contains information on when, like the date when medicines are dispensed and the amount dispensed. So we could use that information to determine the dates when each woman had one of these medicines in her possession. And then when the dates of medicine possession overlapped with the dates of pregnancy, we considered this use of pharmacotherapy during pregnancy. So this means that we've counted both women who received the pharmacotherapy while pregnant as using it, but we've also counted women who received pharmacotherapy before pregnancy as using it during pregnancy, as long as the dispensing was close enough to the conception date to assume that she'd still be making her way through the amount supplied. This approach resulted in a situation like that depicted here, where there was a lot of pharmacotherapy use among pregnant women who weren't recorded as smokers. So we think that some of that would be legitimate, that with women having already achieved abstinence and just finishing the course. But we were also aware that there is an underreporting of smoking during pregnancy in perinatal records. So we suspect that many of the women using pharmacotherapy were actually smoking during pregnancy, but weren't recorded as such. And not addressing this would have led to a substantial underestimate of pharmacotherapy use during pregnancy. So we used various details about the medicine dispensed to reclassify some of these women as smoking during pregnancy and obtain what we think are more realistic estimates of use. I won't go into the details of how we did that reclassification here, but if you're interested to learn more about it, the process is described in the PLOS One article cited at the bottom of this slide. So onto what we found. First, bupropion, we found that it's used by very few women during pregnancy, only 0.2% of women who were smoking since the beginning of our study. Varenicline, since being introduced in 2008, was used by 1.8% of women smoking during pregnancy. And prescription NRT patches were used in 1.7% of pregnancies among smokers from 2011 onwards. So that was when the subsidy was extended to the whole population. Now, I think that the low prevalence of bupropion is not that surprising. It doesn't seem to be that favoured in the non-pregnant population either. The prevalence of NRT may come as a bit of a surprise. It's quite low compared to the use of, or similar to the extended use of varenicline, and lower than estimates in other countries. But it's important to remember that we've only been able to measure subsidised use here, where NRT is also available over the counter and for free through some certain programs and remote area Aboriginal health services. And then the prevalence of varenicline might also be a bit surprising, given that guidelines recommend it not be used at all during pregnancy. But it's important to keep in mind that this includes women who commence the pharmacotherapy before pregnancy or even in the first few weeks of pregnancy. And so they may not have been aware they were pregnant at this time. And this figure shows a bit more detail on the timing of use relative to the date of conception and each trimester. It shows for bupropion and varenicline that most of the use occurred before conception or before the end of the first trimester. And this is consistent with the hypothesis that women may not have known they were pregnant when they were using the medicine. The pattern for NRT is quite different. Its use is not clustered around conception date or early pregnancy, with many women starting NRT quite late in pregnancy when they're probably aware that they are pregnant. Okay, so we'll move on to how we measured the safety of these medicines. So we did this with an observational study, meaning that as researchers, we weren't involved in deciding which women use these medicines. We simply observed the outcomes for women that made this decision for themselves. And this type of study design was necessary and important because of the potential risk posed by these medicines. So giving varenicline or bupropion to pregnant women in a clinical trial is probably not considered ethical, while the safety of these medicines is not known. And the NRT randomized control trials have been possible based on the assumption that it probably is no more harmful than smoking during pregnancy. But even those trials struggle to get large enough samples to produce clear evidence. So in those circumstances, observational studies based on routinely collected data are the only way to get large enough sample sizes. But observational studies are not perfect. They have the limitation that because women aren't randomly allocated, there may be key differences in the characteristics of women who use a quit smoking medicine and those who don't. And these characteristics may contribute to different outcomes. So being aware of this risk, which is known as confounding, we put a lot of effort into minimizing this problem with statistical techniques. And I'll come back to give more detail on that shortly. So here I describe who we included in our safety study. So we were comparing women who were recorded as smoking at the beginning of pregnancy and using a pharmacotherapy, compared with women who smoked at the beginning of pregnancy and didn't receive a pharmacotherapy. For simplicity, I've referred to this group as untreated smokers, but I am aware that that's not strictly correct. They may have received some other form of smoking cessation support. It's just that they haven't received the medicines that we're studying here. And we restricted our untreated smokers to women who conceived in the same calendar period as the pharmacotherapy group to avoid any potential confounding by calendar time. So women who smoked and used bupropion during pregnancy were compared to untreated women who smoked and became pregnant between 2004 and 2012. Varenicline users were compared against women conceiving in 2008 to 2012. And for NRT users, they were compared to women conceiving from 2009 to 2012, but we did restrict pregnancies conceived in 2009 and 2010 to those among Aboriginal women, because the subsidy for NRT was not more widely available until 2011. And we used the same method to identify whether women were using a pharmacotherapy as used in our previous aim. So we considered a pregnancy exposed to pharmacotherapy if the dates of medicine possession overlapped with the dates of pregnancy. So again, a pregnancy was considered exposed if there was one or more dispensing of the therapy during gestation or prior to conception, but the amount supplied was enough to last into pregnancy. So just to go back to what I flagged earlier around having to be careful about avoiding confounding in this study because of the non-random assignment. So to overcome this problem, we put a lot of thought into the ways that pharmacotherapy users might differ from untreated smokers. And then for each woman in our analysis, we obtained information on the characteristics that we considered important from the multiple data sources that we had available in the linkage. And then we used a technique called propensity score matching to make sure that these potentially confounding factors were balanced in our comparison groups. So propensity score matching gives each woman a summary score on all the potential confounders that we measured. And then it only includes women in the pharmacotherapy group and the comparison group if they have similar scores. So for every woman in the pharmacotherapy group, we selected 10 women with a similar propensity score to include in the comparison group. And then we analysed the data with survival analysis because this takes into account the timing of the exposure. So safety was measured in terms of various birth outcomes, like preterm birth, small for gestational age, placental abruption, and the others listed here. And this is a typical set of endpoints examined in studies of medicine safety during pregnancy. They're chosen because they're risks to the mother and the neonate that could theoretically arise from any chemical exposure during pregnancy or gestation. The primary outcome was a composite of these 10 adverse birth outcomes, and then we examined each of the individual outcomes as secondary endpoints. And we also examined the risk of congenital anomalies in the infant, but these are quite rare events and our capacity to do this robustly was limited by our population size. So to the results for bupropion. So after propensity score matching, we had 232 bupropion users in the model. With this number of exposed, there were 4 of the planned outcomes that we couldn't examine because they occurred too infrequently. But for the primary outcome, which is the composite of all outcomes, we found no significant relationship between bupropion exposure and the outcome. And for the 6 secondary outcomes that we were able to model, we also observed no significant relationships. And generally, the hazard ratios were less than 1, so indicates that bupropion doesn't increase the risk of these adverse outcomes. For NRT, we had 328 pregnancies included in the model, and much the same picture emerged in terms of the risk of outcomes. There was no significant relationship between NRT exposure and the composite, and we again were unable to model 2 of the outcomes because of too few events. Now for varenicline, because it was available in Australia quite a few years before NRT was subsidised widely, we managed to get a larger sample of varenicline users. So we had just over 1,000 women matched to 10,000 untreated smokers. And the results here are quite interesting. There's a significant relationship between varenicline exposure and the composite outcome. So the risk of any adverse outcome was reduced among varenicline users. The same protective effect was apparent for 4 of the secondary outcomes, specifically preterm birth, small for gestational age, severe neonatal morbidity complications, and a low APGAR score. And then for the remaining outcomes examined, we found no evidence that varenicline increases their risk, with most of the hazard ratios below 1 or very close to 1. So these estimates for varenicline suggest that not only does varenicline not increase the risk of these harms, but it might actually reduce the risk for some of these outcomes. And that's probably via the protective effect of smoking cessation. So you might recall earlier that I mentioned there'd been one prior study of varenicline safety during pregnancy based on Danish and Swedish data. And that study had just over 300 women using varenicline. So it had less statistical power than we had here, but it did show results in the same direction. So it'd be helpful to replicate this analysis with another large study to determine whether varenicline is indeed protective against adverse birth outcomes. And as I mentioned earlier, we also included an analysis of the risk of congenital anomalies. But because it's a rare outcome, we had a limited capacity to do this comprehensively. So we had much lower numbers than we did for the other analyses because we had to restrict to women using pharmacotherapies during the first trimester, because the fetus is most vulnerable to malformations in the first trimester. So this meant we were only able to look at malformations for offspring born to women using varenicline. And we had 696 women included. But even then, for many of the categories of malformations, we didn't have enough data. So ideally, one would measure the risk of specific malformations, because even within the same body system, malformations can have different etiologies. But we didn't have the sample size for that. So what we could observe is that when looking at major malformations overall and anomalies for the genitourinary system and cardiovascular systems, there was no increased risk among pregnancies exposed to varenicline. Having said that, the confidence intervals are quite wide, so we can't rule out that there is a small or moderate increased risk, and this is an important area to focus on in future research. Okay, so now for the final analysis, which focused on the comparative effectiveness of these pharmacotherapies when used during pregnancy. Recall that our aim was to compare different pharmacotherapies in terms of their capacity to support smoking cessation. But as our study on use revealed, there's very little use of bupropion during pregnancy. So in this study, we focused our comparison on varenicline and NRT. And just as we did with the safety study, we addressed this aim with an observational study design. So we selected all pregnancies conceived from January 2011 onwards, and those that resulted in the delivery before the end of 2012. And then we narrowed the cohort down to women who were documented as smoking during the first 20 weeks of pregnancy. And then within this group, we looked at who was dispensed varenicline or NRT, but only selected those who commenced the course of varenicline during the first 19 weeks of pregnancy, and those who commenced NRT in the first 18 weeks of pregnancy. And I'll come back to why we used that 19 and 18 week cutoff in a minute. But application of these criteria returned 106 varenicline users and 135 NRT patch users. And then, as we did in the safety study, we used propensity score matching to minimize the risk of confounding, and we ended up with 60 women in each group. And so with the propensity score matching, we focused on balancing many of the same characteristics that we'd considered in the safety study, But in this study, we were fortunate to have additional information on the heaviness of smoking. From 2011, the perinatal data collection started to record the number of cigarettes smoked per day in the first half of pregnancy. We were able to use that as a proxy for heaviness of smoking. And another advantage we had in this effectiveness study is that we were comparing women using one medicine with women using a different medicine. And this can really help to reduce confounding because it means you're focusing on women who are probably quite similar in their motivation to quit smoking and probably their level of nicotine dependence. So we matched each varenicline user to one NRT patch user using propensity scores. And after matching, there was a little bit of imbalance remaining on a couple of the characteristics. So we've adjusted for that in multivariate models. So the outcome of this study on effectiveness was smoking cessation, which we measured using information on smoking after the 20th week of pregnancy, which is available in the perinatal records. So women who were recorded as smoking 0 cigarettes per day after the 20th week of pregnancy were defined as having quit. So now that you know how the outcome was measured, I can return to our decision to restrict to women who commenced NRT up until the 18th week of pregnancy and varenicline up until the 19th week of pregnancy. So we did this to allow for scenarios in which women attempt they don't attempt abstinence on their first day of therapy. Instead, they initiate therapy sometime before a pre-planned quit date. And based on guidance in the literature, we assumed this would be 2 weeks for NRT and 1 week for varenicline. So this means that in our study, women who commence NRT at the latest possible point still have the opportunity to use therapy for 2 weeks before their outcome is measured. And for varenicline users, it allows them to have at least 1 week of use before we measure their outcome. And here's what we found. So varenicline was more effective than NRT patches. A higher proportion of varenicline users had stopped smoking by the second half of pregnancy. So that, specifically, it was an extra 24%. And when this is described in terms of relative risk, varenicline users were 2.8 times, so almost 3 times more likely to quit smoking during pregnancy than NRT patch users. Now we need to take the magnitude of these effects with a grain of salt, because you might see there that the confidence intervals are quite wide, but the direction of the effects does suggest that varenicline has superior effectiveness to NRT patches during pregnancy. So that brings us to the end of the results, and I know I've covered a lot, so I'll briefly summarize the findings and then move on to what I think are the next steps and what the implications are. So in terms of use, we found that bupropion is rarely used during pregnancy, whereas varenicline and NRT patches are used by nearly 2% of women who are smoking. Our safety study found that none of the pharmacotherapies was associated with an increased risk of adverse birth outcomes. And the safety study also found that the risk of some birth outcomes was reduced among varenicline users. And then our investigation of the effectiveness of varenicline and NRT patches found that varenicline was associated with a higher rate of quitting than prescription NRT patches. So while I think this study has contributed to a much better understanding of the use and effects of these medicines, there are, of course, limitations to bear in mind when interpreting the results. First is that there's a limited number of women who are exposed to these pharmacotherapies during pregnancy, and so that prevented us from measuring the risk of some of the planned outcomes. It also affected the precision of our estimates. And this was most problematic when looking at congenital anomalies. So we were only able to look at the risk of anomalies for varenicline. We couldn't do that for bupropion and NRT. And also congenital anomalies could only be studied in broad categories, meaning that the study can't tell us anything about the risk of specific malformations. Second is that our data was related to pregnancies that result in birth and didn't include records for pregnancies that result in miscarriage or termination. So this means that there's potentially some selection bias in the study where it's possible that pregnancies exposed to these pharmacotherapies are more likely to result in early loss or termination, perhaps due to early signs of congenital anomalies. The third is that we examined the outcome of prescription NRT patches only, where both patches and other forms of NRT are available over the counter. So this means that some of the pregnancies that we classified as unexposed would actually have been exposed to NRT purchased over the counter. And this would have biased our findings, both regarding safety and effectiveness, towards the null. And then finally, that dispensing data don't provide information about the actual use of medicines. So we couldn't determine whether women in our study actually used the pharmacotherapy or the actual duration of use. And because varenicline is not recommended, it's possible that there could have been a greater discontinuation or non-use of varenicline, which means that we would have underestimated its effects, both in terms of safety and effectiveness. So with those limitations in mind, here's what I think we can conclude from the study and what I think the next steps should be. First, I think it's encouraging that none of these pharmacotherapies were found to increase the risk of adverse birth outcomes. So women who are smoking during pregnancy and their healthcare providers can be reassured in that respect. But it's really important to note that evidence is still missing on key outcomes like stillbirth, specific congenital anomalies, and early pregnancy loss. There's also been no examination of the risk of adverse cardiovascular or neuropsychiatric events when these medicines are used during pregnancy, and those are potential safety concerns that have been raised in non-pregnant smokers. So this means we're not yet in a position to make a claim about the safety of these pharmacotherapies in terms of the whole range of potential risks. Obtaining evidence on rare outcomes like stillbirth and congenital malformations would require a much larger study, probably one involving data from multiple countries, and securing funding for a multinational study like that is currently high on my agenda. But once we do have evidence on the whole range of potential risks, our finding that smoking cessation was more likely among varenicline users than NRT patch users might be useful for informing decisions about which of these medicines a pregnant woman might choose to use during pregnancy. And similarly, our finding that varenicline was protective against some adverse birth outcomes might suggest that if varenicline is found to be safe during pregnancy, it might be the preferred choice. So following on from this, clinical guidelines might then be revised because currently they support the use of NRT during pregnancy, but not the use of varenicline. And then one final thing to note is that we weren't able to examine the effects of combination NRT because this is not currently subsidised by the Australian government. So because combination NRT is emerging as having similar effectiveness to varenicline in the non-pregnant population, this might be another treatment pathway worth examining during pregnancy in terms of both safety and effectiveness. And just before finishing up, I'd like to acknowledge the government health departments listed here for providing data for the study, the 3 linkage units involved, and the funding sources. And finally, to let you know where you can find more detail about each of these studies, the 2 publications there and 1 conference abstract. in the public domain. And yeah, I thank you for your time and welcome any feedback or questions.
It's great, Alice. Julia, welcome.
I've just got to stop sharing, don't I?
Yeah, please don't overshare.
No.
Look, just before we start on that that was such interesting data. Julia, can I get a brief clinical perspective on what you've been hearing, both of the problem and responses?
Yes, thanks, Shane, and thanks, Alice. This is a really interesting set of findings, and it's just such an important area because we've known for such a long time that smoking is a significant risk factor for pregnant women, particularly to the unborn child. And there are a lot of concerns in the community and by women themselves about the harms of smoking on the baby. And of course, some of those harms are due to some of the toxic products within cigarette smoking, but also some of those harms are due to nicotine itself. And that is an important thing to reflect on when we're considering NRT as a treatment in pregnancy, because we know that nicotine can contribute to reducing the blood supply to the fetus through the placenta, and that can lead to the growth retardation and so on. And that's why I think it has been very important to pursue alternatives to NRT, which is otherwise thought of at other phases in life is thought of as a relatively safe treatment, but actually vareniclin's different because it doesn't it doesn't employ nicotine, and that's why potentially it may be safer from that point of view. But of course, everyone's very reluctant to say that a medication is safe in pregnancy until it's been thoroughly tested. So it's studies just like this, Alice, using data from women who are taking the treatment anyway that allow us to ethically follow that and gather information about its safety.
Yeah, I think, one of the things about observational research is that there are concerns around it not being random. And so that does introduce some potential biases, but in some circumstances, it's all that's possible. But maybe what would happen in a scenario like this is that perhaps observational research can give some reassurance around the safety of these products before that they be tested in a clinical trial setting.
That's right. Don't raise questions, of course, for me about, it seemed my reading of your results was that very few women who are smoking in pregnancy are on any of these treatments. And that means that these women continue to smoke and that therefore the fetuses are being exposed to the harms of smoking. So if we know that these treatments confer any benefit greater than smoking, we probably should be considering them as a sort of harm reduction.
Yeah,
absolutely. I mean, the risks of smoking are so severe. They're not small risks. It's pretty hard to think that there could be a medicine that would have even greater risks, really.
Okay, we've got some questions coming in. Dr. Robert Arley, I live and breathe, the pride of South Australia himself. Robert says, nice presentation, and he wonders about, I'll send this to you, Alice, wonders about the risk of relapse postpartum. He said it's a big clinical concern.
Yeah, it would be fantastic to measure that. I guess we're just limited in the types of data available. So, the great thing about studying pregnancy is that we have wonderful, really complete data sources in Australia, but postpartum, it's a bit hit and miss about where you'd find these things recorded. So we haven't gone down that path.
Yeah, but I think Robert's quite right, but it's a serious issue. I got a couple of questions from Irene Francisco. I find very laudatory, useful research. Irene wants to know if, well, firstly, she says that she can see some important consideration here for health professionals and GPs, which I hardly concur with. But says she's keen to know if there are any difference found for Aboriginal and Torres Strait Islander women versus, but did you have enough power to look at that, or?
No, that's exactly it. Obviously, it's a super important question, but we already had very limited numbers in each of our exposure groups. That just wasn't possible.
It's it's a very important issue, but I mean, it's quite right, Irene, to raise it. I'll flick the second part of her question to you, Julia. How might nicotine, you were talking about the issue of nicotine replacement, possible, how could that affect hypertension, which is a clinical problem that can emerge in pregnancy? If someone is experiencing hypertension, would NRT be not recommended, or?
To be honest, Jen, I don't actually know the answer to that question. So I'd have to refer to the textbooks on that. Hypertension tends to be something that we see in the later stages of pregnancy.
Right.
I guess if we're seeing hypertension and NRT was felt to be contributing to that, it may be at that stage that we think that the risk-benefit ratio is then suggesting that we stop any additional treatments, because the main harms to the baby would be in the earlier phases of the pregnancy and the cumulative effects of smoking throughout.
What you're saying is hypertension, preeclampsia, etc., is a late stage.
It's a late stage.
It's not right. Okay. Let me see here. Michael Farrell, now there's another name we all know. Professor Michael Farrell, director of our centre here, says a great presentation, and said presumably there was no data on mental health in pregnancy regarding varenicline. That's to you, Alice.
Yeah, again, it's one of those things that, we could have looked at it, but we weren't confident that it would be captured completely. And so it was questionable about whether it was worth doing. The main data source that we would have used would have been hospital admissions data. And so obviously you're getting the really severe end of the spectrum if you're requiring someone to have a hospital.
What about something like prescribing of antidepressants or something like that?
I guess it's just a bit blunt.
Oh, it is. I know, I agree. Julia, I mean, depression and antidepressants are not coextensive, are they?
Oh, absolutely. And actually a related question that I wondered about, Alice, was to what extent there was information about whether any of these women were using other illicit drugs, because that would obviously impact on the fetal outcomes and so on. Yeah,
that's a good point. So we didn't look at it as an outcome, but we did, in trying to balance our groups to make them as similar as possible, we did look at prior diagnoses in hospital admissions, and drug and alcohol admissions were one of the diagnoses we looked at.
Yes.
Yeah.
Let me see. Ami says showing his use of erudition. The question, I'm not sure if it's from an anonymous attendee, wondering if the possible contributor, I'm not sure, whoever feels they can or can't answer that, please say or don't say. Reduced effectiveness of NRT versus varenicline might be the increased metabolism of nicotine in pregnant women due to activity influenced by estrogen. Are either of you aware of this possibility? I'll flick to you, Alice, first.
Yeah, I mean, I've certainly read about the increased metabolism of nicotine during pregnancy, and I think that's probably where combination NRT is potentially like an important area to look at, specifically for pregnant women, because I think just the monotherapy is much less likely to be effective.
And Julia, are you aware of anything about this?
Like Alice, I've read that nicotine metabolism is increased in pregnancy. And I know that when NRT is recommended in pregnancy, it's suggested that intermittent NRT, such as delivered by gums or puffers, may be potentially, again, another harm minimized strategy compared to the patches, because you're not getting this sort of constant exposure. But it is important to remind that the amount of nicotine being delivered in NRT is much less than women are getting from a typical smoking habit.
Yeah. So combination, sorry, excuse my pitiful ignorance, but combination, I'm assuming you're saying it might be, for instance, varenicline and NRT. Is that what you were saying? Different?
Well, that is one option, but actually it's using more than one formulation of NRT at the same time.
Oh, I
So
see what you mean. Yeah,
supplement
right.
your patches with some gum, or
Yeah, right. I understand.
yeah, to help
which
with the
might
more
affect
acute.
the delivery and the frequency of delivery, go through craving or something like that. Yeah, gotcha.
Right. So with the intermittent forms, like the gum, you get a hit a bit quicker into the bloodstream.
Yeah,
Patch gives you a steady,
which might get you over
level.
a craving spike. Yeah, got you. Now let me see. Rebecca McKeaton said she's heard bupropion is more commonly prescribed in New Zealand than here, and she was wondering if there are any data linkage sets that could be used to evaluate the impact of bupropion vis-a-vis New Zealand, for example. I don't know.
I mean, so I have been working with a group in New Zealand who have a similar data set around prescription medicines in pregnancy. I think they didn't find much use of bupropion during pregnancy at all, but
Right.
and they have much higher rates of NRT use during pregnancy, but I think that's just because their subsidy for NRT is much more flexible.
Yes.
And cheap. It's cheap to get subsidized NRT.
Yeah, I
in
can
New
understand
Zealand.
that. There's a couple of questions here. It's we've got a question from Karina Coe, who says, I'll flick this to you, Alice. Do you think how's the prevalence of NRT use in pregnancy during the study period, which I think ended in 2012? Karina's wondering what might that be like in more recent years.
I'd like to know.
Yeah. Is there a reason why the data does lag so much?
It takes a really long time to build these data sets.
Yeah.
I mean, more so back when, so this grant was funded in 2012, and it took 4 years from the time of getting ethics approval to have the data delivered. It's definitely getting more efficient now, and we have a linkage just like this in process, but that's why there's just.
But linkage. Basically, in answer to that question, we're not really sure. Now there's a question here from Nicole Hallahan. I work actually out. How do we get the message about to clients? And I can ask, might flick this to both of you. To clients who only know about patches, they may not know about varenicline, and your evidence is quite. I'll start with you, Alice. I mean, if the implication is that this drug is a serious consideration, how does one get that information out? Besides speaking here today, obviously.
Yeah. Well, I guess I think before answering the actual question, I do just want to reiterate that I don't know that we're at that point of saying varenicline should be recommended during pregnancy.
Yeah. Fair enough. Yeah.
But I think at the time that, if that does become a likely outcome or a good, what we want to see happening, then I think clinical guidelines.
Yeah. What do you think, Julia? I mean, is clinical guidelines the way to go, assuming that it is a viable alternative to NRT, or there are other ways to approach the population of GPs and specialists?
I think one of the things to highlight really is that if a woman is thinking about becoming pregnant, she might be, she would definitely be best placed to seek advice in the year prior to that and try smoking cessation products at that time, because that takes away all the worry, obviously.
Yeah.
It also, I think, was clear in Alice's data that there was an underreporting by women of smoking in pregnancy, and there's a great shame attached to the fact that you continue to smoke in pregnancy when you know it's harmful to your baby and you don't want to do it. And it therefore prevents or certainly delays help seeking. And I think probably having conversations early or even before pregnancy, but even when women are pregnant, we have to try and be non-judgmental in our approach and, accept that for some people smoking is an addiction which is very difficult to shake, and try and enable a conversation along those lines. So, I mean, that's before we even get to clinical guidelines. I think that's just good practice for trying to engage women in the conversation.
Yeah, a comment is probably pertinent to this from Emma, saying that Quid and Alfred Health, in collaboration with Royal Women's Hospital Pharmacy Department, have clinical guidelines for smoking cessation using an algorithm for prescribing NRT. So supporting smoking cessation during pregnancy using NRT. So, I mean, basically it includes combo NRT for those with high nicotine dependence. There's clearly clinical movement in this field, Alice.
Yeah, I think that's right. It just hasn't happened at that national level.
Right, yeah. Now, Michael is just, we're coming towards the end of that time. Michael Farrell was asked, can you use the pregnancy data set that you'd have access to explore other behaviours in pregnancy? And of course, he's thinking of drugs such as maintenance drugs for opioid dependence, such as methadone and buprenorphine.
Well, yeah, and the data set that we have doesn't have that particular data collection in it, but the one we're building now does have
the bigger, better one.
Exactly. I think it's got 21 different data collections in it.
Wow.
So there's certainly scope to do that. And yeah, it's definitely something I want to do.
There's the next 10 years of your life gone. That's,
yeah.
Look, I think we'll wrap up now. It's been such an interesting, it's a fascinating and important issue. And I looking back, I think I've heard far too few talks on it over the years, and it's great to have heard an excellent presentation. And so Alice, that was wonderful, and Julia, it was really great to get your clinical observations. It's great to have this confluence of research and clinical expertise, and I thank you, both of you, very warmly. It was an excellent session, and I would also like to thank those of you out there in the audience for your attention. I hope you've enjoyed this, and we'll be back on the air next Thursday at 3 p.m. So wish you all a lovely afternoon and excellent evening. Thank you.
Thanks, everyone.
Thanks a lot. Thanks, Alice.
Julia.